Namaskaram and a very good morning. I am Soumya Swaminathan, Chairperson of the MS Swaminathan Research Foundation, former Chief Scientist, World Health Organization. And I want to thank you for allowing me to share this short video with you with my reflections on the Vision 2031 for the state of Kerala. And I thank you for having invited me to participate in these discussions, and I truly apologize for not being with you in person. I would like to briefly give my views on what are the strengths and weaknesses of the healthcare system in Kerala today, and basically looking forward at an agenda where Kerala almost becomes a sort of a pathfinder for the rest of the country. So I think most of us will agree that if you look at the strengths of the Kerala health system, it's built a very strong network of public facilities with good geographic access. The primary healthcare has been a focus, and there has been sustained investment in this, and there is also a lot of public utilization of these services, and this can therefore explain Kerala's low infant and maternal mortality and high life expectancy. The other aspect, of course, is that the human development and the social determinants have also, had a lot of investment and attention over many decades. So you have, very high female literacy. You now have 100% digital literacy. There is near universal schooling. Kerala is now free of extreme poverty. There is better nutrition, sanitation, and social awareness, and of course strong local governance and decentralization. And we know that health outcomes are driven as much by the social determinants of health and equity, social equity, as much by access to healthcare services. The third strength is effective public health capacity, and despite the fact that Kerala does not have a public health cadre, unlike Tamil Nadu, there is a very good and strong disease surveillance and outbreak response. We've seen in the recent past response to COVID, but also the response to Nipah and other emerging viral infections. There is very good leadership during these crises, and there's good coordination between public health, local governments, and communities. So Kerala does retain a public health mindset, not just a clinical one, and recent investments in the One Health Institute and in preventive oncology and so on also point in that direction. Then we have community trust and participation, also very strong features, again because of the decentralization to local bodies and very empowered panchayats. There's a lot of community engagement. There's trust in the public health authorities, and women's groups, civil societies, and local panchayats have an active role to play. There's also been a lot of attention to things like mental health and palliative care, which continue to be challenges, but Kerala is ahead of other states, particularly when we see the community-based palliative care model, of course led by Pallium India and Dr. Rajagopal. Kerala is a good example for other states on how to deal with this. Now, if you look at what are the weaknesses, or you can say emerging challenges, the first is, of course, the high burden of non-communicable diseases, both due to people living longer and due to many other lifestyle-related risk factors. We find diabetes, hypertension, and all of the complications of these diseases, and aging-related diseases, neurological, cancer. All of these are increasing and likely to increase further. So the system is designed originally to deal with acute problems, infectious diseases, maternal and child health, where it's done very well. The paradigm is now shifting to a chronic disease model. Aging population, Kerala is probably the state which is aging the fastest, and therefore there's a rising demand for geriatric, long-term and home-based care, and this strains both families as well as health facilities and services and requires new care models. The third is out-of-pocket expenditure. Despite the fact that Kerala has a good public healthcare system with good geographic access, the burden on financial burden on families, out-of-pocket expenditure continues to be high, and there's a great reliance on the private sector, particularly for diagnostic services and for specialist care. And therefore, this, though we have good health outcomes, but it goes side by side with financial vulnerability. Human resource constraints, again, a lot of migration of doctors and nurses outside the state. There are gaps in specialist availability in public facilities, and the quality of care is uneven, especially when we see beyond primary care. Then there are a lot of intra-state and urban-rural inequities. So while overall the state indicators are good, if you really break it down and see in tribal areas and hilly areas, you'll find that there are vast differences in health outcomes. So average excellence can actually mask some of these pockets of neglect. Then there's the financial constraints, limited fiscal space. Traditionally, there's been high social sector expenditure, but now the costs are rising because of what we just talked about, chronic diseases, non-communicable diseases, and so on. Therefore, sustaining this high quality of care and standard of care is going to require more efficiency and prioritization, not just a mere expansion of services. So I think to summarize, Kerala is moving from infectious diseases to chronic disease, from just survival in terms of life expectancy to improved quality of care, and a healthy life expectancy should be the outcome that we're measuring, and from a younger population to an older population, an aging population, and therefore we also need to think differently. It's not just now about reducing mortality. Of course, premature mortality due to non-communicable diseases is increasing. That is, people who die below the age of 70 due to NCDs. But we need to really look at chronic care, patient support, and financial protection. So if we look ahead at, say, a future reform agenda for the Kerala health system, we will have to redesign the health system for chronic care and aging. So because of what we talked about, the actions will need to be that you have to establish these chronic pathways. So rather than seeing every program in a silo or seeing every level of care separately, we will need a continuum of care approach, sort of a life course approach where we follow the individual who may have different and overlapping diseases from time to time. We will have to expand family medicine and geriatric care as specialities, which is neglected in all states. Integrate home-based care, community nursing, palliative services already happening, but will need to be further strengthened, not just for palliative, but even for just looking after the old people in the community. And we have to look at primary care as being the coordinator of long-term care, not just the first contact and providing kind of episodic care, but really being the place or the center of where chronic care is coordinated. So referral up, referral down, the follow-up, the dealing on a day-to-day basis with the issues that patients have. And of course, digital technologies and tools can play a big role here in supporting and empowering the health workforce to actually carry out. In fact, it will be a must. There will have to be a digital nerve center which enables this kind of continuity and tracking of services. Rationalizing the duplication between the private and the public sector will also have to be thought of. Then the other challenge that we talked about was the financial risk. This needs some thought on how do we reduce the out-of-pocket expenditure while maintaining a good quality of care and a strong public system. So for this, we need to expand diagnostics in the public system, because a lot of out-of-pocket expenditure goes towards diagnostics. So both diagnostics and essential medicines need to be looked at and expanded. Of course, strengthening price regulation and strategic purchasing of services from the private sector. Also thinking about how the private sector, are there models like the capitation model that's used in Thailand, where the private sector is also made responsible for primary health care and health outcomes and is basically paid for maintaining or delivering good health outcomes in the community, not just paid for the service provided, like for a surgery and so on, but rather expanding the scope of the strategic purchasing to also preventive and promotive care. Investing in the health workforce of the future. So we'll have to have a model, a kind of reskilling and ongoing mentoring program for doctors, nurses, and all levels of healthcare providers, including the mid-level health providers, the ANMs, the ASHAs, also working with the Anganwadis and other kind of maybe volunteers, community health volunteers that we have, because the challenges of migration, of burnout, of specialist shortages, some of it can again be addressed through telemedicine and so on, through remote consultations. But we will also have to think about career pathways for these different categories of the health workforce, creating family physicians, skill upgrading. So some states have experimented with anesthesia or simple surgical interventions where a person who's not a specialist, who's not done an MD or an MS, can also give anesthesia. I think there was a study that was done by the Gudalur group and was published, showing that you can give anesthesia, non-anesthetists can also provide. So we need to explore such models because we'll always have a shortage of specialists. So tele-mentoring, hub and spoke models, these are all, and setting up a skill academy or making arrangements for ongoing mentoring and skilling of the health workforce needs to also focus on retention of the workforce and role redesign, not just recruitment of new staff. Putting mental health at the core of the system. So really, I think we know that there's a growing burden of mental health, and so it should not be an afterthought, but it should really be treated as foundational. And again, because of the shortage of specialists, of psychiatrists in our country, we need to use some of these other models of expanding counseling and psychosocial support, and really in schools and colleges, for example. So again, focusing more on prevention, on identification early. Similarly, for in children, neurodiverse children, identifying them early and putting them into sort of programs which give you the right kind of stimulation and support for neurodiverse children. And mental health, these need to be thought of again from a more preventive point of view, and again using non-specialists. Then looking at the intrastate inequities, so focusing on tribal areas, finding those pockets where the health outcomes are poor, and doing micro-planning, use data to identify communities that are lagging behind, and designing the health system again to look at equity as foundational. We talked about digital health will be very much a part of everything that we do in the health system, but again, how to strategically use digital health so that we're not overburdening people again. So often what happens is that we overburden the same frontline health workers who are collecting data on paper as well as digitally, and not using the data that's being collected sufficiently. So ensuring that we collect the data that we need, that we reduce or eliminate duplication of data collection, and that data is used locally for decision making, and also using digital tools for digital support, for enabling the decision support systems, and also using, in some cases, artificial intelligence, particularly for screening of x-rays or pathology, again if there are shortage of specialists, but all of that needs to be evidence-based. Fiscal and governance reform will need to be thought of. Again, of course, health being a state subject, initiatives can be taken by states, but a lot of the central sector schemes and the policy design comes from the government. So this would have to be a larger discussion, I think, around the National Health Mission and how that needs to now look at the current challenges, because it was designed 20 years ago, and we need to look forward now. We also need to look at, are there institutions in the state that need to be either built or strengthened? The State Health Resource Center, the Health Technology Assessment Centers of Excellence, the Food Safety Organization, the Drug Regulatory Center, the State Drug Center, the procurement for diagnostics and drugs like the medical supplies corporation. So we need to see, and a health research unit as well within the Department of Health, which can support, fund, and coordinate a lot of operational research and these kind of interim assessments and impact evaluations of programs to see how they're doing and whether they need mid-course corrections. So essentially, I think that Kerala is, again, as I said at the very beginning, could be a pathfinder because India is aging, but Kerala perhaps is ahead in terms of this demographic and epidemiological shift. It has a very strong foundation of primary care, but these new challenges are really something that need us to reimagine and perhaps transform the way that we've been doing healthcare. We know that we have defined health workforce, but we also have a very highly literate population that's very intelligent and able to make decisions and perhaps uses a lot of social media as well. So the ways in which we communicate and dealing with mis and disinformation as well. So health communication is going to also be a new area that will require some investment along with the other state level institutions that I mentioned. So thank you very much for your attention, and I will be happy to be available, I hope, for at least part of the discussions online. Thank you.